Bismillahirrahmanirrahim. Professor, Chair, and dear colleagues, first of all, I'd like to thank the organizing committee in inviting me to share in this prestigious meeting. The title of my presentation is How to Carry Out a Randomized Controlled Trial, RCT. RCT is the best type to use when the objective is to establish the efficacy of a treatment or a procedure. It is the gold standard or reference standard in medicine. It provides the greatest justification for concluding the cause and effect. It is the subject of least number of biases. Nevertheless, it is expensive and it needs a long time for follow-up. And this is a resume of the different types of study design in medicine. We have two basic types: observational studies and interventional or experimental studies. In observational studies, subjects are observed and there is no intervention, while in the interventional or experimental studies, intervention is done and the effect of intervention is observed, and there is another unclassified type, which is the meta-analysis. There are four types of observational studies: case series, case control, cross-sectional, and cohort studies. The initial step in the observational studies is to generate hypotheses through a case series study, which is the simplest study design. The author describes some interesting observations having a small number of patients and leading to generation of hypotheses. The subsequent step in the observational studies is that the hypotheses generated by case series studies are further investigated by the other three types of observational studies depending upon two factors. Number one, duration of time, and number two, direction of time. For duration of time, a study that represents only one time, we call it cross-sectional study. A study that include extended period of time, we call it longitudinal, which include case control and cohort study. And according to direction of time, a study that is representing a simultaneous event, that's to say today, is called a survey or cross-sectional study. A study which is backward-looking in time, representing yesterday, we call it case control study. And a study which is forward-looking in time, that represents tomorrow, we call a cohort study. In the middle, you see today. To the left side, you see yesterday. To the right side, you see tomorrow. A study representing today is survey or cross-sectional study. A study from today to yesterday is case control study. A study from today to tomorrow is cohort, and the study from yesterday to today is a historical cohort study. Again, cross-sectional study represents a time which is right now. It is called survey study and answers the question, what is happening right now? Case control study represents a time in the past. It is called retrospective study and answers the question, what happened? Cohort study represents a time in the future. It is called prospective study and answers the question, what will happen? For the interventional or experimental studies, intervention is done and the effect of intervention is observed. This could be controlled or non-controlled. And according to the time correlation between the study and the control, usually the study and the control groups are carried out simultaneously. Therefore, it will be parallel or concurrent. This could be randomized or non-randomized. If the study and the control are following each other, that's to say sequential to each other, this could be a study with self-control or crossover study. If the control is carried out many times before the study, this is called a study with historical control. This is the design of randomized controlled trial. At the onset of the study, we choose subjects which are meeting entry criteria. Then we do randomization into two groups, experimental subjects and control subjects. This is by the intervention, and then we do a follow-up, and at the end of the follow-up, among the experimental subject, we will study subjects who will develop the outcome and subjects who will not develop the outcome. And at the end of the study, among the control group, at the end of the study, we will see who will develop the outcome and who will not develop the outcome. What is the difference between cohort and randomized controlled trial? In a cohort study, there is no intervention, as the item under study is already existing and observation is done forward in time. While in randomized controlled trial, there is intervention through deciding to give or not to give the item under study, then observation is done forward in time. In randomized controlled trial, decision to give or not to give the item under study is done by randomization. And these are the most common types of controls. Number one is the gold standard reference standard or standard of care. Number two is placebo, and number three is sham. For the first time is the gold standard, which is something that has passed the test of time. This could be a treatment modality like medication or a surgical procedure. It could be diagnostic modality like radiological, endoscopic, or histopathological modality. The second type of control is the placebo. It is used in pharmaceutical studies. The drug under investigation is tested against a phantom having the same shape, color, weight, and taste, but having no effective material. Placebo is important to nullify the psychological effect of receiving the treatment. The third type of control is the sham operation. It is used in surgical experimental studies. The animal is opened, the concerned organ is identified and dissected, then the wound is closed. Sham operations is important to nullify the effect of anesthesia, incision, and closure of all wound layers. And there are so many types of randomization, but the most common and the simplest are the closed envelope and the computer-generated random tables. Then what about masking? The degree of masking depends upon the information, whether it is available to the patient or to the doctor. In open label studies, the information about the study are available to both patient and the doctor. In blind studies, the doctor knows the nature of the study while the patient doesn't know. But in double-blind studies, neither the doctor nor the patient know the nature of the study. Then, randomized controlled trials as a part of drug approval. RCTs are not suited to initial investigation of a new treatment. When used as part of drug approval process, RCT are frequently referred to as phase 3 trials. And this is a resume of different phases of clinical trials. The first is the preclinical phase. It includes in vitro studies on cell lines, then in vivo studies on small, then big animals. And the purpose of the preclinical phase is to adjust the dosage regimen and to evaluate the potential toxicities. Phase 1 trial is initial effort to administer the treatment to the human being. It includes human volunteers. It provides only a preliminary look at the potential efficacy of the therapy, and it includes a small number of volunteers. Phase 2 trial, usually a small-scale controlled or uncontrolled trials. The aim is to establish whether full-scale RCT should be conducted. Phase 3 trial, it is the classic randomized controlled trial. The FDA requires 2 independently conducted RCT before reviewing a drug for approval. Phase 4 trial is the post-marketing trial. It includes studies after FDA approval and use of the drug in the market. Then what about the sample size in RCT? To calculate the sample size in RCT, we have to consider 2 important points. The first is the power of the study, and the second is the expected difference between the study and the control group. To study the power of the study, we have to consider type 1 statistical error and type 2 statistical error. Type 1 statistical error is the probability of demonstrating a statistically significant difference in selected samples when no true difference exists between the treatments and other several different samples of the same population. most investigators accept type 1 error at a range of 5%. And this is a classic example of type 1 statistical error. If we assume that the objective of any study is to study the correlation between gender and prevalence of renal cell carcinoma, then the authors compared 100 males versus 100 females for duration of 10 years for the possibility of occurrence of renal cell carcinoma, and their results showed that females has a statistically higher incidence of renal cell carcinoma because the p-value was less than 0.05. Type 1 error here, if you repeat the same study by several other investigators with the same number of patients but with different samples of the study population, the results will be statistically not significant in all other studies. So type 1 statistical error is a false positive because of random error in your sample. Type 2 statistical error is the probability of failing to demonstrate a statistically significant difference in selected samples when a true difference actually exists between treatments in larger population, and most investigators should aim for no more than 20% type 2 statistical error. And this is a practical example of type 2 error. If we assume that there is a study, the objective of which is to study the effect of new adjuvant chemotherapy in survival of patients with bladder cancer, then the authors chose 100 patients who were subjected to new adjuvant chemotherapy followed by cystectomy, and another 100 patients who were subjected to cystectomy alone, and then they did a follow-up for 5 years. The results came like that. There was no statistically significant difference between both groups because the p-value was more than 0.05. Type 2 error here is if the sample size was 1,000 in group 1 and 1,000 in group 2, the difference will be statistically significant. So type 2 statistical error is a false negative because of a small sample size. You see that if the result of the study there is no difference, and in reality there is no difference, so there will be no error. If result of the study there is difference, and in reality there is no difference, this is type 1 statistical error because of random error in your sample. If result of the study there is no difference, and in reality there is no difference, there is no error. If result of the study there is no difference, and in reality there is a difference, this is type 2 statistical error because of small sample size. What about the power of the study? A 20% type 2 error is also referred as an 80% statistical power. The statistical power plus type 2 statistical error adds to 100%. The 80% power implies 80% probability of being able to demonstrate a statistically significant difference between the samples if a true difference exists in the larger population. Then the next item to calculate the sample size is the expected difference between the study and the control arms. You look to the previous similar articles, and the expected difference equals the expected outcome in the study minus the expected outcome in the control group. And this is a very simple rough table that identifies the sample size related to the difference between the study and the control group. If the difference is 25%, the sample size will be 50 in each arm. If the difference is 20, the sample size will be 100 in each arm. If it is 10, the sample size will be 250. If it is 5, the sample size will be 500. And if it is 1 only, the sample size will be 3,500. So the larger the expected difference between the study and control arms, the smaller the sample size. And the smaller the expected difference between the study and the control arms, the larger the sample size. The previous examples were set on the assumption that type 1 statistical error was adjusted at 5% and type 2 at 20%, so the statistical power is 80%. If you wish to obtain more statistical power, you have to increase the sample size. And this is the table that is shown in the books of statistics. On the left side, you will see the probability of the adverse outcome in the control group, and to the right side you will see the probability of adverse outcome in the study group, and in the middle you will see the type 2 statistical error, and according to the choice of the type 2 statistical error you will obtain the power. If the type 2 is 10%, the power will be 90%. If type 2 is 20, the power will be 80. If type 2 error is 50, the power of the study will be 50. There is a computer program which is called the G-Power, and this is available. This is a free software available at Mac OS X and Windows XP Vista 7/8. This can help you, the authors, to calculate the sample size of randomized controlled trial. And this is an example how to calculate the expected difference between the study and the control groups. A randomized controlled trial studying the effect of alpha blocker tamsulosin on the increase of the spontaneous passage of distal urethral stone less than 10 millimeter. Previous articles showed that the expulsion rate in the tamsulosin group was 90% and the placebo group was 65%. So the difference will be 90 minus 65 will be 25%. So the appropriate sample size is 50 patients in each arm, provided a statistical power of 80%. This is the Consort Flowchart. The word consort, it is not an English word. It is an abbreviation of the sentence consolidated standard of reporting trials. The Consort Flowchart is a fundamental chart that should be available in every randomized controlled trial that could be accepted by a journal of high impact factor, and it consists of 5 stations. The station number 1 is assessment for eligibility. That includes the number of patients included in the study. Station number 2 is enrollment, which include number of patients excluded from the study. The third station is allocation, which include number of patients available for randomization. The fourth station is the follow-up. That includes the number of patients lost for follow-up. And the final station is analysis, which includes number of patients available for analysis. And this is an example of, a practical example of Consort Flowchart. We start by station number 1, which is assessment for eligibility. That include number of patients chosen to be included in the study. And stage number 2 is enrollment, which include exclusion of some patients. In this example, we excluded 20 patients. And the third station is allocation by randomization. The 120 patients were divided into 2 equal groups. Each group contains 60 patients. And the fourth station is the follow-up. Among group 1, among the 60 patients, 5 patients were lost for follow-up. And among group 2, among the 6 patients, 6 patients were lost for follow-up. And the final station is the analysis. The number of patients available for analysis in group 1 was 55, and in group 2 was 54. Thank you very much.